Welcome, everyone, and thank you for joining in about transition care, exploring the journey. I am Martine Pergent. I am the president of IPOPI, and it is my great pleasure to be your moderator today. IPOPI is the International Patient Organization for Primary Immunodeficiencies, and medical education about this condition is one of our most important jobs. Before we begin, I would like to take a moment to thank Grifols for making this learning opportunity possible. I am delighted to welcome our guest speaker today, Dr. Nizar Mahlaoui. Dr. Mahlaoui, you are a pediatrician specialized in immunohematology at Necker Enfants Malades University Hospital in Paris, France. And you will help us explore the journey that is transition care. We also have the pleasure to have with us Dr. Virgil Dalm. Dr. Dalm, you are an internist clinical immunologist in the Primary Immunodeficiency Center at Erasmus MC Rotterdam, the Netherlands, and you will be bringing the adult perspective to our session today. Dr. Dalm will also be answering some questions in written on the chat. You can find the biography of our two speakers in the chat as well. Please do use this chat to let us know where you are joining from, and feel free to say hello, because we want this session to be interactive. Do use the question tab that you can find on the right-hand side of your screen to ask questions, and after the presentation, we will answer some of our questions with both Dr. Mahlaoui and Dr. Dalm. Dr. Mahlaoui, you are also the coordinator of La Suite. What is La Suite? You will explain this in the following video segment.
So in France, the transition care for patients with more and more organized around 18 years old, with usually shared consultation with both the pediatrician and the adult physician, and also the parents, obviously. This moment is very critical to ensure that everyone involved in the care of the teenager is fully aligned in terms of knowledge and perspectives. So La Suite here at the Necker Hospital is an innovative and comprehensive program working with also the adult hospitals in Paris, because obviously this is about transitioning the patients to an adult facility. And we here at La Suite have a team of people who are fully dedicated on that topic of transitioning patients with rare diseases and also chronic diseases here at Necker. And we build this framework on top of what already exists in the reference centers for each rare disease that we have here, which is basically half of the rare diseases known so far. 4,000 rare diseases are followed here in Necker.
What a journey! We need more explanation for you, and we are thrilled to hear more about exploring this journey. Dr. Mahlaoui, the screen is yours.
Thank you very much. Thank you to IPOPI for inviting me to talk about transitioning of the pediatric care setting to the adult care setting. Thank you very much also to Virgil Dalm, who is an adult internist medicine in the Netherlands, in Rotterdam, Erasmus Medical Center, and who is also very interested in the subject. So we'll have a lively webinar, I hope. So there there will be time for everybody, I guess, to ask questions, and I have prepared some slides. So, PIDs, primary immunodeficiencies, are not only pediatric diseases anymore. They were mostly known by pediatricians, and there are now more and more patients who are diagnosed during adulthood, but also more and more patients who transition from the pediatric care setting to the adult care setting. So if you look at the figure on the right part of the slide, it is a figure that I built from the French National Registry of Primary Immunodeficiencies. More than 6,000 alive patients, and as you can see, the median age of patients living with PIDs in France is 23 years old. So it means that half of the population is 23 or older, and it means that it's really not only pediatric disease anymore. So PIDs are rare, but multiple, more than 450 different PIDs. They are all chronic diseases. A lifelong management is required. Sometimes they come with complex comorbidities or conditions, and you probably know that among these comorbidities there are infections, obviously, but also severe allergies, autoimmunity, inflammation, lymphoproliferation, and malignancy. So all patients require a specific management, which is really high-level management and care, with immunoglobulin replacement therapy for half of the patients. 15% of the patients might require transplantation or gene therapy. There is a need for specialized units, and especially in the adult care setting with trained medical doctors. So this is something we can discuss during the webinar. And transition care is needed for patients who have been diagnosed during the pediatric age. So a recent publication from the European Society for Immunodeficiency Registry, with almost 16,500 patients, was recently published, showing that 3/4 of the patients have been presenting symptoms of PIDs before the age of 18. So really the diagnosis could be made during childhood and teenagehood for many, many of these patients. And the PID groups is as follows. Almost half of them have a predominantly antibody disorders, mainly CVID or IgG subclass deficiency, for example, and other well-defined PIDs such as Wiskott-Aldrich, phagocytic, combined immune deficiencies, sorry, as a third group, and phagocytic disorders as a fourth group, such as chronic granulomatous diseases, and obviously there are other groups as well. So basically, a PID team is really a team that work on a multidisciplinary level. We have contacts with general practitioners, nurses, even in the ambulatory setting, physiotherapists, but also non-PID specialists, such as pulmonologists, ENT specialists, gastroenterologists, dermatologists, so the list is really long, but also social workers, etc. We also work very closely with the clinical immunology lab, and sometimes some teams have a dedicated bone marrow transplantation teams. And of course, we work very closely with the patient association. So really the key word here is networking, and you can do that on a daily basis, on a weekly basis, on a monthly basis. And this is really something that we are trained to do. And I think this is really one of the pillars of what we can build for a successful transitioning. So really, transitioning is really, moving from teenagehood to adulthood. So in Japan, there is even a public holiday for that. I don't speak Japanese, so I won't pronounce the word, but it's really an official public holiday. The youth are invited to attend the ceremony in the city hall, during which they are congratulated and they are wished to follow the same path as the generations before there. So it's very interesting to have that at a cultural level. But coming back to primary immunodeficiencies, we can now diagnose some PIDs, mainly severe combined immunodeficiencies, the SCID or the bubble boy disease, by newborn screening, and even at that time, we can mention that there will be a lifelong follow-up that will require transitioning from the pediatric care to the adult care, even if the patient is cured with a bone marrow transplantation or a gene therapy. And as you can see in the middle of the picture, I was in a meeting in a hospital, in a pediatric hospital, and I found that sign, which I thought was very illustrative of how pediatricians think, and especially pediatricians dealing with rare diseases. So you can see old children's outpatients. So that really, because of the fact that we've been working so hard on improving the outcomes of these children, we've been keeping them, so to speak, pretty long after they reach 18 years old. So there are now, better survival, better outcomes, and improved quality of life, although much is still, to do to improve these outcomes. But clearly, compared to 20 years ago, things are really getting, better. And we have improved the socialization and the well-being of PID patients. And we all want the same thing at the end of the day, is that these patients become fully active citizens contributing to the society. And this is really what they want. But as you can see in the little doodle at the bottom of the slide, there is a brain maturation that happens to everyone, every teenager, meaning that we now know that the brain finishes its maturation at age 25. So making proper decision for the rest of your life when you're 18 is not really physiological. And this explains why some of them might be lost in translation. So a few verbatims of patients that we follow at the Necker Hospital regarding transitioning. I don't know my doctor's name because he or she introduces him or herself with his first name. We have a bond with the patients that we know sometimes from starting birth, and we see, or maybe once a month or even once a week sometimes. And some patients say, I will never leave my pediatrician because of that bond. My doctor doesn't answer when I ask her, when am I going to die? This is really something that I heard. And interestingly, at the bottom of the slide, you can see I prefer to be seen by an adult physician because I got a more frank dialogue. So it's not really all patients were not having a PID. There were also cystic fibrosis patients with diabetes. But one very interesting topic that they discuss is the coverage of the expenses of their treatment, so the cost of the treatment when they turn 18. Will I need to pay for my treatments? And because I don't have, I don't have any money. So, and of course, in France, it's something that is covered by the National Social Security. But I am aware that in some countries that might not be necessarily as easy or even the case. So the teenagers are not that shallow, and they are really thinking about important topics, and they're kind of anxious about that. So what is transition really? It's a purposeful, planned process. So really, the keyword here is planning of the medical, psychosocial, and educational and vocational needs as the children or teenagers move from the pediatric care setting to the adult care setting. So it's really a lifelong process, or at least for a few years, starting usually around age 12 or 13 and ending around age 20, 21, meaning 2 or 3 years after the transfer is performed. So the transfer is really the moment in time where the medical file is handled by the pediatric team to the adult team. So the goal of the transition is really to maximize the lifelong functioning and potential of these youth through the provision of high quality, developmentally appropriate healthcare services. So really also it's really important to understand that when you're 13 years old, you don't need to know the same extent of things regarding the transitioning as when you are 17 or 18. And the last key word is that we want to have a continuity of care. We don't want any interruption. So why do we need transition care? It's really an issue across the whole of healthcare. There is mainly because there is a need for a defined and coordinated pathway guiding the teenagers towards adult services. And why so? It's because we have loss to the system, we have no-shows, we have patients with poor compliance regarding their treatment, and it might lead to potential irreversible organ damage, lower their quality of life, lower their life expectancy even. And all of that has health and cost implications as well. So there is really a vital need to ensure the easy access to essential healthcare and support during this period. And we really need to work on the reassurance of patient and family and move the bond between the pediatric care setting to the adult care setting. And really, it's a work in progress, and it's a cross-fertilization between the pediatric healthcare professionals and the adult healthcare professionals. We really learn from our adult colleagues as much as they learn from us as pediatricians. So I've prepared a few quiz during the webinar, and if you want to answer, there's a poll section, and you can start replying. There is a single good answer here. When should transfer to adult services take place? At age 15, at age 17, at age 20 or 24, or age should be adapted to patient's readiness. So maybe I'll leave you a few seconds to answer. And so people are still voting, so that's nice. Thank you very much for playing along with me. And maybe I should mention the answers. So it's half of the answers are age should be adapted to patient's readiness. And I think it's really, really interesting that you answer that, because it's really what we think we should do. Although I know that in some, it might be the case that in some countries, pediatricians have no choice really but to transfer to make the transfer to the adult care setting at age 18 and not above 18. So obviously it depends on each country. But chronological age is not the best determinant for appropriate service provision. Transition from children's services should be based on the needs of the young person rather than a particular age. So after a planned process, the caregivers and the patient and both medical teams should be involved in this planned process, and usually around 18, but it's really upon information, willingness, autonomy, and readiness of patients and caregivers as well. If, in the case of multiple family members affected by the PID, maybe you want, if it is possible, to transition all patients together. I mean, if they're close in age, if they're a 16-year-old and an 18-year-old, you might want to wait to transition both patients. If there are PIDs with some kind of syndromic features, such as developmental issues or psychological issues or cognitive issues, it might happen a bit later, maybe. And also, if you consider multiple transitions because there are multiple comorbidities and multiple doctors or multiple healthcare professionals involved and multiple hospitals. As you can understand, it can be a kind of a kaleidoscope, and you might want to really make things happen a bit slowly, or at least to maximize the coordination. One thing that I should really stress is to avoid absolutely really transfer during an acute complication. So hospitalization in an adult setting where the patient has never been, that he or she doesn't know anyone, and vice versa, nor the emergency room. So that we don't want to do that. It's not the proper way to work. So services are really mismatched in some cases, and thresholds are different, and sometimes it leaves the patients with limited option. We should really help them to optimize their outcome, and really we want them to be an active member of these decisions, and they have their say in that. So really, it's important. So how do we do that? So usually we start at age 12 or 13, just by really mentioning that in some years from now there will be this transfer to the adult care setting, and the family and the youth and the provider slowly move from a certain position to another position, and ultimately what we want is that the teenager becomes the manager or the supervisor of his or her own health, that the caregivers, so the parents, should really step back a little bit and let their teenagers and young adults be the manager that he or she needs to be. And this is really a work that is done on a slow fashion. This should move, but anyways, this patient in the middle of the slide should transition with his or her healthcare plan, and receive the support during the whole process, and should be accompanied during the whole process. And we should not forget that the parents should also be should receive also support, because it's also a difficult time for them. We'll come to that a little bit later. So this is more what it really looks like or feels like, and it seems like a little bit hectic and disorganized, but there are solutions, there are support groups, there are lots of people involved, and with goodwill, good voluntary and knowledge on how to work. So that I kind of like this slide because it's really more of the reality. So another quiz, and if you want to take the poll maybe. So the prerequisite to a successful transition should include the transfer of the pediatric file. So there might be several good answers there. The presence of the pediatrician by the side of the adult physician during 1 year after transfer, the active participation of the patient, the implication of the parents in the adult sector, sharing information between the different healthcare professionals involved. So I see that people are voting. Thank you. So maybe, yeah, I think people still voted. So I'll move to the next slide. So transfer of the pediatric file, sharing information, active participation of the patients. I think that implication of the parents in the adult sector received the least score, but I think it's really important that they get still implicated at least during the first months or year, and sharing information between the different healthcare professionals. So I think I'm really running a bit behind time here. So you'll have the response to the quiz of this quiz. Sorry, I have to move on. what you can probably continue my slides here. You can find some structured assessment before transfer for parents and for the youth, and it's helping to know what, to assess what the patient know or doesn't know, and how we could work to improve that. In France, for the PID, National French PID Center, we have worked on a structure file to summarize the medical history with the PID diagnosis, what kind of information parents and patients know about their prognosis, the late complications, the genetics and the inheritance, the relevant history, the therapy, and also the psychological impact, the schooling, the education. So it's in French, but it's totally free of copyright, so if you want to adapt it to your centers. So outcome measures, so obviously the continuity of care, what about the no-shows, the loss to the system, the compliance issues, the ER visits, the preventable emergency hospitalization, the organ damage. All these are outcome measures that you can monitor and to really look into whether the transfer has been successful or not so successful. Also ask about quality of life issues and patient satisfaction with regards to the process. Self-efficacy, health literacy, and disease-specific knowledge is something that you might want to work on, and there are some programs of patient therapeutic education that can help. So for adult physicians, our conundrums and challenges, these diseases are often rare and maybe even ultra rare, and there are multiple diseases in the PID universe. We're really cutting edge, so it's uncharted territory. What about the complications that we don't know about, because it's really the first time that patients with some specific PID get to reach this age. So there are unforeseeable complications that can happen, and we really need to work closely hand in hand. There are other topics that patients are very interested in, and that we should not forget when they move to the adult care setting. This is the professional integration, social integration, the psychological impact of their disease, the handicap, the neurocognitive impairment, the communication skills of the adult team is really key. Multidisciplinary care should be continued, and really adult physicians dealing with PID should really work on that. But sometimes there are no defined network, and they feel that they have to improvise. So we should really help that, and this is another milestone. I think I've already dealt with that. There are other topics that matters to the youth: romantic relationships, having a good social life, easy access to drugs and alcohol. This is something that matters to them. Identity issues, financial issue management, keeping safe, academic pressures. They are often worried about transitions and feel pressure to do it on their own. So really we should not forget about that. So the parents, what about the parents? They should talk and share information with the teenager after the transfer is done. Let the teenager alone with the HCP during the consultation, at least partly part of the consultation for the first time. And they should ask their children or teenager for a post-consultation summary and not really be kind of intrusive during the consultation. So the key points is really trying to optimize health and facilitating each young adult attaining his or her maximum potential. We should start early, and we should also involve caregivers and primary care provider. It's an ideal time to rethink diagnosis and management. So, for example, negative genetic investigations done long ago might be redone now because we have other techniques that can provide positive genetic documentation and, again, go beyond strictly medical issues. So if you want to have more resources, you can look into these leaflets. There's the IPOPI leaflet, the IDF leaflet, leaflet on being a parent with a teenager and chronic disease by Dr. Lotte Denning, and there are a few publications in the field. Thank you.
So, thank you. Now, the moment you have been waiting for, we will answer some of your questions, and I can see that we have many in the chat. So, Dr. Mahlaoui and Dr. Dalmo will take the screen for your questions. So, first question maybe, and it's a very simple one, I suppose. So, every adolescent ages differently. So, do you have a cutoff age level for treatment by pediatricians? A cutoff age.
Well, if the question is regarding when should we transfer, yeah. I think I addressed the question, and I think it's really variable from a person to another. Just maybe it's not really a good idea to transfer when the teenager is 13 or 14, and it's not really a good idea to wait until 25. I'm guessing, because as a pediatrician, I'm not very knowledgeable in some topics that really are very specific to the adult world, regarding the social security or, whatever. So around 18 is what is usually done. Mm-hmm. Sometimes you can wait a little bit depending on the readiness.
Okay, and now what happens? Let's go to the stakeholders. So the parents, the physicians, and the adolescents. Let's say, what happens if the parents are not willing to cooperate because their child is perhaps becoming more independent after quite often going through difficult times? Does it happen to you that the parents don't want to cooperate?
Yeah, not that often. Really because of the fact. Or thanks to the fact that we have planned this. I mean, the first reaction that we get, or that I get, is usually, "What? No, we don't want to." They're scared. Because this is really the first time that they hear that. And it's just because they don't know, the adult medical team. So we need to talk about that, and we need to come back to this during the next consultation, and we can give them a tour of the adult clinic, or we can show them a picture of a group picture of teams, because we work together usually. We know each other, and then they get reassured. And one very important thing is that the transfer consultation. So the consultation at the time, it has a huge symbolic charge or meaning, because it's really both the adult and the pediatric team with the parents and the teenager, and everybody has the same level of information. Mm-hmm. And it's really, we take usually 45 minutes for this consultation. So we really talk about everything, not only the medical issues, but also, social life, what they want to do as studies or traveling abroad. Do they want to have, they plan to have maybe children in some day, in some time. And this is really important to them, that they feel that they can ask any question that they have in mind.
And now going to the pediatrician, does it happen that a pediatrician doesn't want his patient to leave, him or her?
Yeah, it would be interesting to have Virgil's insight on this, I guess.
The pediatrician.
Very quickly, I have to say, to be honest, there are some times when pediatricians do not want to. Not only in the rare diseases or the PID or rare diseases field, but also, for example, in the hem-onc setting. Even when the patients are cured, for it's been a long time they've been cured, they have some kind of emotional bond that makes it difficult to achieve. But maybe, Virgil, you have another take on that.
Oh yes, I fully agree with that, because I mean you can also understand because many of these patients you see for a long time, they grow up under your, let's say, guidance at the outpatient clinic. So you have not only let's say a doctor's relation with the patient, but also get more and more emotionally involved. So it's always difficult to to say goodbye to such a patient that you see and grow up and have all these sometimes dramatic episodes you encounter together. So yes, it's fully understandable. That's of course difficult. I mean, from both perspectives, from the doctor's perspective and also from the patient's perspective, because these are indeed very used to getting in touch with you for 16 years or whatsoever. So
yeah.
that's
anyway, Virgil, it's you that I would like to challenge now. Based on a question from Bruce Lim from Malaysia, many young adults find that adult care are not so caring compared to pediatric ward. Hence, many young adults stay back in pediatric ward for their treatment and care. What is your comment on that?
Yes, so I mean, also that is quite understandable, and I think that the most important, it's also what Nizar already mentioned, that it really has to do with preparation, because of course the attitude of doctors may differ, well, from a one-to-one base, but also pediatricians and adult physicians, I think they indeed communicate different with their patients and also with family members of the patient. I mean, and if you do not prepare patients very well, it becomes a bit more difficult. I think it has all to do with preparation and introducing the transfer, so getting or letting patients get used to a different attitude. Because what my personal experience is with our transition patients, that indeed when we didn't have an official transfer program for these patients, at the age they went 18, they had to make an appointment with the adult physician. They had to come alone. They were not there with their parents. So then, of course, it's completely different. So let's say today you are with the pediatrician, your parents are there with you, and 6 months later you have another appointment with a doctor you don't know, without your parents at a place you don't know. So that's not the way it should be. So that's, I think, you have to get used to that process. You have to get used to that new department. You have to get used to the new faces you will see. So that's why this transfer or transition process takes or needs to take longer. So not when you are 17, next appointment when you are 18 to the adult hospital, but you have to take some years to really prepare for these transfer. And hopefully with a good preparation, you can convince the patient and the parents that also adult physicians may be nice.
Yeah, it looks like there is another kind of difference between the pediatrician and the adult physician. And given to Otilia Standa from Romania, supported by Maria Chararambos from Cyprus, many young adults complain that the adult PID doctors only looks at the IG levels and give them IG replacement, not look at their problems at the whole, like they used to be seen in the pediatric ward. What are your comments on that, both of you? So maybe between Dr. Darren, because you are on the
Yes, yeah, it's a very nice topic to discuss on. Yeah, I mean, first start, I hope that's not the case too often, that adult physicians only look at IG levels. But I can understand what has been posted as a question, because it could have, because it's also another question that has popped in the questions section quite often, that what to do if there are not so many adult immunologists.
For my next question.
And well, it could have to do with something with the same topic, actually, because that's my opinion, or what I may experience over the past years, that many patients that were seen in a specialized pediatric unit for primary immunodeficiencies, once they get the age of 18, they are transferred to an adult physician, but not necessarily an immunologist. So they are transferred to internist, general internist, or infectiologist, or a hematologist, which is it's not a bad thing itself, but most of these adult physicians do not have too many experiences with patients with primary immunodeficiencies. So with the upcoming number of clinical immunologists, I hope that is improving for adult care. Well, along the way, we see that also adult care for these patients is improving, because also, like the teams that are set up for pediatric patients, also teams are now set up for adult patients. So I hope with the rising number of adult physicians really focusing and specializing in primary immunodeficiencies, that this gap will also disappear.
Yeah.
Maybe I can. Thank you very much, Virgile. I totally agree with you. There is really a difference in cultural, the way pediatricians work and the way adult physicians work. But it's really not the opposite. I mean, I learned a lot from my adult counterparts, and I think it helped me improving my practice. What I could maybe mention as potential options is that the interns, so the young doctors in training in the adult internal medicine or infectious diseases who are interested in dealing with rare diseases should probably do some internship for 6 months. This is usually the timing of an internship in France in a pediatric clinic. Mm-hmm. It's really interesting that they get a sense of how pediatricians work, because this is really how patients, when they move to the adult setting, will be used to be, guided or something. And I think it's really interesting, and we have lots of them doing so. And I also think that pediatricians should also spend 6 months in the adult ward. Another thing is that I was one of the contributor to the creation, to the launch of the first transition clinic in an adult hospital in France. So starting from what we have done at La Suite Necker, there is the counterpart in the adult hospital with which we work most. It's really a first. And when we thought about this, the general idea of the physicians working in this adult hospital was that really thinking about transitioning of young adults is helping us improving the way we do our everyday work with the whole population, even the elderly. Mm-hmm. I thought it was really interesting.
Yeah, very interesting. It looks like there is one stakeholder missing, and we have a comment from Anneli Larsson from Sweden. I have experienced that often practical, easy, organized things can really make the transfer smoother. For example, easy for the patient to reach the nurse by email or phone, easy access to testing when the patients get infection. The nurse at the adult care unit is very important. Do you want to comment on that both?
No, yeah, I think it's really fundamental. I usually, I totally agree with that. We need it's a multidisciplinary work, and obviously nurses are really one of the pillars of a successful transition process.
Roger?
Yes, well, fully agree with that. I mean, without a nurse, you cannot do. I mean, those are, well, in our experience, the first one to be contacted. So in general, that's also like the suggestion in the question that indeed, when we do the transfer process to the adult ward, we provide information on an email address, on a telephone number from a nurse. So that could be the first contact person with any question. So, and we also have, well, a telephone number for, let's say, emergency questions, an email address for questions, well, that need to be answered in few days. But that's something that you really need good information, but also indeed easy access to the outpatient clinics. True.
So this is something I didn't show in the second part of my slide because I was running, behind time. But in the mobile app that I built it with La Suite Necker, a physical ward that you saw probably during the little movie trail. This is exactly what I tell the patients to do, is really to enter the name and the coordinates, the email, the phone number of the nurse, of the secretary, of the physician as well. Really, both, all these people are key to really make sure that they always get a proper answer.
Yeah, I'd like to have a last question for you, and especially because I know that you are experienced in world region like Africa or Asia, both of you. And I would like to get your advice for countries where PIDs are still recognized as only being pediatric. What could we advise to those patients who are children and are growing up, and what would you advise for them, knowing about the reality of those countries?
No, yeah, I think it's really really important. I remember I discussed this with my colleagues in Morocco, for example, and the thing is that you can, as a pediatrician or a team of pediatric healthcare professionals, you can always start building networking and connecting with the adult counterparts in different specialties: internal medicine, infectious disease, hematology, pulmonology, etc. And you will find people who are interested in working with you to ensure that the proper follow-up of these patients is doing, is organized. And of course, you have to start, step by step, slowly. But I know that now it's been a few years that they've been working on this, and they have now a very nice network. So it's really a work in progress, and you should start somewhere.
Yeah, Virgil, about Asia, especially because I know.
Yeah, well, I think I fully agree with what has now said before, because we all focused on the need of, let's say, dedicated clinical immunologists, but I think the most important is that you have dedicated specialists. So that's what Nizar also mentioned. So, in every hospital there are infectiologists, hematologists, internists, pulmonologists, and indeed you will always find some people that are interested in this rare disease. So if there are no clinical immunologists, but you have dedicated hematologists, there is no difference in quality. It's about the dedication and interest of the adult physicians. So, in a place where there are no dedicated primary immunodeficiency specialists, you have to generate them yourselves, indeed, and start building a network with people from your hospital or surrounding hospitals that are interested. So, it's not only internal medicine from an adult perspective. It's also gastroenterology, pulmonology, ear, nose, throat diseases. So then you have to find your people that want to work on this topic.
And their cooperation between physician and patient organization are paramount.
Yes.
Yeah.
Of course.
Absolutely. So we have reached now the end of this webinar, which was made possible thanks a kind donation from Grifols. On behalf of IPOPI, I would like to say a warm thank you to Dr. Mahlaoui and Dr. Dalm for this excellent session and for all the answers you provided. If we did not have time to answer all the questions, do not worry, we will be sending the answer by email. So, thanks again to all for attending this IPOPI webinar. If you have a minute to spare, please share your feedback on the webinar by pressing the link shared on the screen. You can see right now the link will also be posted on the chat. Please note that you will be able to see the recording on IPOPI TV within a couple of days. We encourage you to share it as much as you can to those who you think will benefit from it. See you next time, and please keep safe. Bye-bye.